Good morning, everyone, and welcome. It's the 26th of January 2026, and it's now 3 minutes past 10. Very sorry, we did have some connection issues. So, Zach, we'll move on to apologies.
Good morning, Chair. I've received apologies from Councillors Kelly, Luca, Adcock, Jones and Johnson.
Thank you. Do we have any declarations of interest? Okay. So, firstly, I'd just like to say that we... can I... Sorry, I do apologise. So, the minutes. Do we approve the minutes of the meeting held on the 1st of December 2025? Yes? Okay, thank you.
Can I just ask, Chairman, if we've had any news on the urgent treatment centres in that report? You know, it's supposed to be...
Not yet, but we can pick that up as part of the work programme if you
Thank you very much, Zach. Thank you.
Okay, thank you. Firstly, I'd like to say that we understand that there have been 2 critical incidents declared by UH&M this winter. I just wanted to give the committee and members of the public that we are aware of this, and we are going to consider working groups later on in the year to see how we can improve this in the future, and that we're going to have committee meetings and working groups in the future to look into the winter plan for the end of this year. Okay, so first off, I'd like to introduce Councillor Martin Rogerson, Cabinet Member.
Oh yes, it is. We've gone the wrong way. Yeah.
You're giving me the wrong information.
No. We've just taken it out of order. So yes, it's
the ICB first.
No, it's going to be Richard Harling's item first on the agenda. If we can just do a swap around.
Okay, so we're just going to do a quick swap around. So we're going to introduce the Cabinet Member for Health and Care, Martin Rogerson, to do his report, Dr. Richard Harling and Claire McIver. That's no problem. I'd like to introduce you to give us your report on healthy weight in childhood.
Thank you, Chair. So this is an opportunity this morning for you to consider the draft Director of Public Health annual report for this year. And we've chosen this year as our topic to do healthy weight in childhood. I'm joined this morning by Rochelle, who's one of the commissioning managers, and by Tony Bullock, who's the commissioning lead in the Public Health and Prevention team. The report is in your pack in draft form. Unusually, this is an officer report rather than a political report, although the Cabinet member will, of course, have a keen interest. If it's okay, Chair, I'd like to open with a very short presentation that covers some of the key items in the report, and then perhaps we can get into any points of discussion. So, presentation is up on the screen there. This basically follows the format of the report. So first of all, a sense of the scale of excess weight and obesity in society. These are obviously broad estimates, but for younger children, that is children aged sort of 5 to 11, we're looking at around 6,000 who are overweight and 5,000 who are obese. Older children, sort of 11 to 18, those numbers are higher, so about 11,000 overweight and another 17,000 obese. And then when we get into adulthood, we're looking at about 280,000 adults in Staffordshire who are overweight and about 190,000 who are obese. There we go. Those figures do vary a little bit by district, so there is a graph in the report that gives you the rate of overweight and obesity in year R, which is reception year, and you can see how that varies a little bit between district. There is a clear correlation between deprivation and obesity, which is that on the whole, those wards that are more deprived do tend to have higher rates of overweight and obesity, and that applies to both childhood and adulthood. That doesn't mean that all wards that are more deprived are more obese, or vice versa, but it is a general correlation when we look at all the wards in Staffordshire. And we did include a little map at local area so people can see how that data applies at smaller area level. The health impact of overweight and obesity is profound. You can see from that coronal section on the right there the physiological burden that excess weight puts on the human body. Being overweight or obese increases the risk of a whole range of serious medical conditions, diabetes, heart disease and strokes, many cancers. It also has impacts on mobility and mental health as well. And it's a dose-response relationship. So the more overweight or obese someone is, the greater their individual risk. The economic impact is also profound. The total cost of overweight and obesity to society is estimated something around 100 billion per year. A lot of those costs fall on individuals. It's the cost of early onset of ill health and death and the costs to family and friends of looking after them. There's a cost to the NHS estimated at about 20 billion per year, and there's a cost to wider society from benefits and from lost productivity, again in the order of 15 to 20 billion per year. At its very simplest, overweight and obesity is due to the relationship between calories consumed and calories burned, so an imbalance between people's diet and exercise. What we've tried to highlight in the report is that viewing it that simplistically is probably the wrong approach. People do not make individual choices in a vacuum. Their choices are shaped by the society and environment in which they live. We currently have an environment where high-calorie fast food is very readily available and very heavily promoted, and where opportunities for physical activity are less than they would have been, let's say, 50 years ago. So in that context, the rise in overweight and obesity we've seen in the UK and other developed countries isn't particularly surprising. The question is, what do we do about it? There again, we need to look at a balance between individual action and personal responsibility and changing that cultural and economic environment in which people live and work. I'm going to hand over to Rochelle now just to tell you briefly about Better Health Staffordshire, which is our approach to try and encourage a healthy weight in the county.
So I think just a couple of words of introduction before we hand over to Rochelle with the detail. As Richard's alluded to, this is probably the biggest challenge for public health that we're facing nationally and in Staffordshire. And I think it might be useful to think about it in terms of smoking. As I'm sure many of us will remember, about 1 in 2, 50% of people smoked in the 1980s. It's much closer to 1 in 10 now. Now, that didn't happen overnight, and it didn't happen with a simple solution. The whole range of different things that happened during that period, whether it's changes to taxation, smoking cessation treatment services, changes to advertising, smoke-free homes. There's a whole range of things that central government, local government and other partners did to achieve that huge success. We're embarking on a similar journey with Healthy Weight. It's not going to happen overnight, and it's not going to happen just by the actions of the County Council and local partners. What we do have to do, though, is make sure that we maximise the resources available to us locally and through our partners. And the Better Health Staffordshire programme that Rochelle will describe is our attempt to build that foundation for the long-term programme and make sure that we're maximising what we've got available to us locally with our partners. So I'll hand over to Rochelle.
Thanks, Tony. Thanks, Richard. Our response to the challenge and the complexity of the system that we're working in is the Better Health Staffordshire programme. Like Tony said, it's a long-term and preventative initiative. So what we're trying to do is tackle the causes of excess weight, physical inactivity and poor diet, and enable and empower individuals, families and communities to eat healthy, be more active and maintain a healthy weight. So we have a number of goals which, as you'd expect, are aligned to that mission. So we want to see reductions in excess weight in children and adults, of course, as well as more children and adults eating a healthy, balanced diet, more physical activity in children and adults, and less physical inactivity in children and adults, a distinct difference. So in terms of the approach that Better Health Staffordshire is taking, it's a whole system approach, which means creating the conditions for change. And everyone has a role to play in that, so it's everybody's business. And like Tony said, it's a long-term endeavour. So in terms of what those conditions look like in the Better Health Staffordshire programme, firstly, partnerships and communities. Sorry, Richard, next slide, please. Or is that the right? Oh, no, sorry, that is the right one, isn't it? Sorry. So firstly, partnerships and communities. So our strategic infrastructure for the programme consists of a county-wide partnership with a range of partners that attend that meeting that's held every other month. So the ICB, MPFT, we've got dietitians, Support Staffordshire, Together Active, skivvies, the districts and boroughs are involved, obviously colleagues from Staffordshire County Council, including our public health team and active travel team, for example. So we come together to ensure there's that coordinated action across the county. And then that's complemented by arrangements that we've got in the districts and boroughs, and that differs depending on the area and what those needs are. So, for example, in Newcastle and East Staffordshire, we've got our own Better Health Staffordshire partnerships, and we run a Newcastle one in a family hub. But in South Staffordshire and Tamworth, for example, we land our Better Health Staffordshire approach in those existing health and wellbeing partnerships. So collectively, all those partnerships make up our Better Health Staffordshire network, and that way we're able to distribute easily the same information, evidence, guidelines, local success stories to that network. In terms of communities, we really welcome the voluntary and community sector to be the voice of the community and share what's happening on the ground in terms of those enablers and barriers. And then moving on to data, insight and evidence, we use this to help shape and drive our work. So, for example, at the county-wide partnership, last week we shared, or the Public Health Intelligence team shared, some of that data around the new childhood excess weight information. We've gone to developing healthy settings and environments, and that's really about ensuring that everyone's got access to good food and that everybody is able to be active in their everyday lives. So some examples of that work, we're undertaking a school food survey to understand the enablers and barriers to healthy school meals from the perspectives of head teachers, parents, carers, as well as young people and children as well. So bringing in the Voice Project to help us with that. We provide evidence to the local districts and boroughs and their planning officers in terms of developing local evidence to support developing local policies to restrict fast food takeaways near schools, and that's in line with the National Planning Policy Framework. We're working with the Family Hub, we work with them really closely. I'm sure you'll be aware they have a whole load of fantastic work that happens in the Family Hub, so we're just working with them closely to see if we can pilot a community cafe next year. We're also involved in conversations with early years providers, and they've had some new early years nutritional guidance that came out nationally last year. So we're going to work with them just to understand how we can address fussy eating, how we can address the unhealthy relationship with food from that very, very early age, because what we're seeing is that tracking into schools. Moving on to providing access to information and guidance that supports healthy choices. So we've developed a local campaign that you hopefully have seen, the Just Add Veg campaign that we've got. So that's really around a pledge to eat more veg, so making it very visible to our communities that there are small actions that they can take to help increase that consumption of vegetables. And then finally, on that condition for change is implementing and measuring sort of impact and embedding learning element to the programme. And that's really about making sure that we're creating the right environments for the space to learn and to knowledge share in those partnerships. And these conditions for change have now become our work streams for the Better Health Staffordshire County-wide partnership. In terms of how stakeholders can engage, we really welcome people to commit to the mission and to champion the approach through connecting with external partners, internal partners and communities, and really collaborating with us on creating those conditions for change, whether that be at an individual level, family, a system level or policy level.
Thank you, Chair. We'll finish the presentation there and invite comments, questions, anything else. Thank you.
Okay, Catherine.
Good morning, everybody. Thank you very much. I think it's a great example, actually, the smoking cessation. And I think that's very clear to us all here today. That's a great example. I'm just keen, as a Needwood Forest County Councillor in East Staffordshire Borough Council, on their Health and Wellbeing Committee, I'm really keen to understand a little bit more of what's happening with stakeholders around this area, for mine area, and East Staffordshire Borough Council, but obviously I presume other councillors would like more detail as well on that, please. Thank you.
Yeah, so we have the East Staffordshire Better Health Partnership that runs every quarter, and that's chaired by our colleagues at the district and borough, so that's not chaired by us. We have a range of partners that are on board at those meetings. We have an action plan that I can share with you if you'd be interested. So the themes across the action plan are around food, environment and move more. So those are what the partners have chosen to take forward, and we've got actions against each of those. There was a recent report that went to the council, and that was before Christmas. So again, I can share that report with you. So that provided an update on progress.
Have any follow-up question? Okay. Jill Hood, Councillor Hood.
Thank you, Chair. Good morning and thank you for that presentation. I've read it with great interest, and it's great what's being proposed here and what's already in place. But I understand, I'm a school governor, and I understand the pressures that are on families, the time constraints, the economic constraints. And I was talking to a family the other day, and the mother worked 2 jobs, and it was quicker for her to pick the child up from school, dash to McDonald's, and then on to her other job. And this is what's happening. I think that we've got to use education. We've got to use early years education. And it's good to hear that the various hubs throughout Staffordshire are doing this. And I think also my local school has begun lots of free extracurricular activities. And the economy is definitely driving obesity. And until we find a way to relieve the pressure on our families who are working 2 jobs, 3 jobs with young children, juggling their time, not having the time to actually plan meals. I mean, it was great at Christmas when we went into every single supermarket, sprouts were 5 pence. But how many families actually took advantage of that because of time constraints? And I really, really think it's great the work that you're doing, that we're doing, but schools, education is the key to reducing obesity. Thank you, Chairman.
I mean, I have to agree, it is not easy for people, is it? And that's part of the thrust of what we're trying to get at here. We have included in the report some what we hope are inspiring examples from across the county of where local communities have come together and tried to make life and those healthy choices a bit easier for people. And we hope that through the Better Health Staffordshire programme and with the commitment of everyone, these are examples that can grow.
Okay, thank you. Do you have any follow-ups? Councillor Parton.
Good morning. Thank you for the presentation. It was quite good with all the figures and everything like that, but I find them a bit misleading because they haven't included all the people with illnesses and diseases which cause to put on weight. And I think it's sad that we're leaving them lot out and saying, look, you know, they're not included in the report. So I think people with illnesses and diseases and medication that causes you to put on weight, I think they should be included as well. Thank you.
Yes, thank you for that. And there will be it will be a relatively small number of people who have underlying conditions which do predispose to overweight and obesity. The trend we've seen over the last few decades applies to the whole of society, actually. And if you can imagine a distribution curve of weight, you know, the number of people who are perhaps underweight, the average in the middle, the number of people who are overweight, what's happened is that curve has shifted to the right. So the whole of society has got heavier, which means that there are then more people on the kind of very heavy end. So what we tried to do is aim this at the sort of the broader population. That's not to ignore those people with underlying medical conditions, but I think the sort of actions we're keen to promote is societal-wide action rather than focusing on again, a relatively small group.
I think they should be included in the report as well to say that proportion of people can't help their weight or can't help that they've got an illness which causes them to put on weight. And I think it should be included within the report to say there is a percentage of them that's included and can't, you know, help their weight and whatever.
Thank you. Yeah, we can reflect on that. Thank you.
Okay, thank you. Councillor Wallins.
Thank you, Chair. Yeah, it was a good report indeed, and what I find interesting is roughly 60% of residents in the report classed as obese or severely obese and so forth. But when you look at local neighbouring authorities such as Birmingham, you know that their percentage is about 30%. Stoke-on-Trent is just shy of 35% in terms of obesity for residents. What these neighbouring authorities do better compared to Staffordshire?
So Staffordshire's, broadly speaking, our rate, the proportion of people who are overweight and obese is about the same as national, so we're not out of kilter. I think the difference sometimes depends on who you're actually thinking about. So we've got about 2/3 of adults who are overweight and obese, so they fall into that broader category, and we've got about 1/4 who are obese. So I think you may be comparing that quarter with figures like 30% from Stoke. Again, broadly speaking, we're not particularly unusual UK-wide, but I guess on the other hand, we've got nothing particular to celebrate just at the moment.
Thank you for that. And the other question I've got is, I know, especially when it comes under a broad range of things, but the Healthy Start cards, it's mainly for a lot of people on certain benefits or pregnant women who are pregnant and so forth. But would it be possible to consider broadening the eligibility for the Healthy Start card to make more families in deprived areas easy to access, to buy fruit and veg and so forth?
It's national, isn't it? Go on.
Yeah, so that scheme, that is a national scheme with national eligibility. So yes, Healthy Start, and you're right in terms of the vouchers for fruit and veg. Yes, we can look at how we increase uptake within that eligibility so that people are able to access those vouchers. Yeah.
Thank you. Thank you, Chairman.
Thank you. Councillor Edgeler.
Thank you very much, Chairman. Thank you very much for your report, and good morning, everyone. I want to really, we sit as councillors on committees and that and trying to make the right decisions. And I'll take you back a few years, actually, sitting on the planning committee at the borough and talking about children and obesity. And we had an application come through for a fast takeaway between a primary school and a secondary school, right on the doorstep. Because thinking about obesity and children and thinking about their health, the borough rejected the application. It went to a planning inspector, and this is where I'm coming from, actually, and the planning inspector passed it. Now, what can we do as a committee or yourself to get through to these planning inspectors that these fast food takeaways between two schools are not good for children's health? Because it says starting well. Well, we're not starting well by a planning inspector giving permission for a fast takeaway between two schools. So I'm just saying, what can we do to alleviate that? Do we write to somebody at government and say, look, this is the situation? Thank you very much, Chair.
I'll come in on that one. So the National Planning Policy Framework now has it in there to restrict fast food takeaways that are near schools and close to where children congregate. So that is in there. So our role is to support the districts and boroughs and the planning officers in developing that evidence. So it's that bit that we need to do and to make that really strong case. And what sits really well with the inspectors, because I know this has been through Newcastle Council, is that whole system approach and where that sits within that. So it's just not just one thing that we're doing, but it's, it's that multifaceted approach, and the inspectorate likes that. So locally we have got some good evidence but of how that's worked. But yeah, absolutely, we need to make sure that that evidence stands up to scrutiny and stands up to the inspectorate. And it's an issue across the country.
Thank you, Chairman. I'll certainly keep my eye on that. Thank you.
Okay, that's a great question. Councillor Greatorex.
Thank you, Chairman. Slide 25 is a very powerful one because it covers quite a lot in terms of the recommendations. Some of the things have been spoken about already. Councillor Hood's thing about getting to the school and early year settings. Councillor Edgeler about planning permission for takeaways. But there's so much there. I mean, there's things like more provision of green spaces, more exercise, more considered meal times and consistency there. And because it's so diverse a slide, there's so much going on, and they're all the sort of things that we know, but we choose to not necessarily concentrate on too much at any one point in time. I wanted to digress a little bit and go with me and mention Michael Mosley, now deceased, but they've started repeating his programmes on Radio 4. It was on last night. And one of the things that Michael Mosley said is you just do one thing that makes a difference. And I wondered, in relation to all of the different things that are contained within this report, and I'm not saying any of it's not valid, but are there some beacon projects that are going on in the county which are significant, which the county is proud of, that would help help focus people on things that will really make a difference? I'm thinking of one in particular. My GP practice had some pre-diabetic classes where it was online, and you got some guidance on things like portion control, mixing the various components of a meal, so you got your protein, you got your vitamins, and you got the right portion size. Now that was quite valuable because you're learning in a class, and it was significant in terms of the learning potential to take part in something like that. I don't know if that's been successful and rolled out elsewhere. It happened to be a GP practice in Lichfield that I participated in. But are there other beacon projects that the county should be proud of that would help in terms of communicating the overall messages?
So yes, there's plenty of really good work that's going on locally, especially in our communities. But there is also the adult weight management service for people who are living with obesity. So that's available in Staffordshire and delivered by Everyone Health. And there's also the Family Weight Management Programme delivered by Time for Sport. So there are some services that are available as well. So whilst the Better Health Staffordshire programme is focusing more on the prevention, there is what's called the Tier 2 sort of services available for those that need it the most. And within that, they have got things that you've just described, so around portion sizes, around healthy swaps, meal planning in the family weight management one. So there's some excellent work going on, some really good outcomes in those. But yeah, we could definitely share those more, absolutely.
As I say, there's a lot of good things going on, but it's how you put that focus on to make the real difference. You know, if there are some significant benefits from pre-diabetic classes or going into a classroom and explaining what a meal composition should be, if there are examples of that happening in different parts of the county, it's worth amplifying that by putting a focus on them.
Just to come in on that, I think what you've described there is the National Diabetes Prevention Programme. That's an NHS programme, but we work in partnership with the Integrated Care Board on that to promote the service. So our job isn't to commission the actual intervention. Our job is to promote it, and our team work closely with the NHS colleagues to try and increase the number of referrals into that programme, because as you described, it does an awful lot of positive things. So we are trying to promote those things that we know work, but there aren't any silver bullet things that work for all audiences. So that's fabulous in the goals that it's seeking to achieve, but there's lots of other goals that we need different programmes to try and achieve at the same time.
Okay, thank you. Do you have any follow-up questions? No. Okay, Councillor Brown.
Good morning again. Yes, in short. Would you like to go first? No. Okay. Yes, talking about... Oh, well, we'll see. I don't think so. So talking about projects, I'm really interested to hear about Better Health Staffordshire. And there's already probably a very small proportion of children that go out to farms for education. Part of my role is I feel it's really important, and something that I can do is to bridge the gap between, shall we say, the rural community, rural businesses, and the county council and all the other associated stakeholders. So what I'm really interested to know is, although some and a few children go out to farm for education, and I know at one at Field at Uttoxeter that's an excellent example, but I think there's a great area that we could take more children out to rural communities. They could be educated on food and food growing. They could even have simple cooking skills at the time, which is then relevant to them. You've also got the opportunity for them to have physical activity, but it's really important that we hit and target those children who need it most, not the children who, if you like, are doing the Duke of Edinburgh or the parents are paying to go on trips. We need to get the children who really we're talking about today, those children, but it comes at a cost, because you need to pay for those children to go on buses. We need the cost of the implementation with schools. I'm sure there might be something already going on, but I think we have a huge opportunity because, you know, Staffordshire is a fantastic... the amount of dairy industry that's in Staffordshire, I think it's something like 6 or 8% of dairy products, fruit growing. I know there's lots of rural businesses who are really open to having children out. And I think it's probably a huge untapped resource and a really positive issue that we could all work on. And I would actually like further conversations on this, if I may. Thank you.
Yeah, thank you. Welcome the suggestion and happy to have a conversation. Thank you.
Okay, thank you. Is any follow-up on that? No? Okay. Councillor Hood.
Thank you, Chairman. There's one glaring omission in the report, and I'm fed up of hearing about it, and that's screen time. It's incredible to watch the young people going into school and their phone is stuck there and they're not speaking to each other, and it's incredible the amount of use. And apart from nutritional guidance to our parents and to our schools through education, I wonder how involved we are, and you are, with educating young people that You've just come from home, you've probably sat for 2 hours on your screen, you're going to go home tonight, you're going to sit for at least 4 or 5 hours on your screen, you're going to go to bed, the likelihood is you're going to sneak your phone or your whatever it is that you're using. And it really is having a dire effect on our young people. And I'm not saying that we restrict it totally, but I think education, bringing screen time into our education would be really helpful, because they are so inactive, and that has to be contributing towards the obesity problem in our division. Thank you, Chairman.
Yes, thank you. I think the screen time is really interesting points. Time for sport that I mentioned earlier, that's something that they address within that family weight management programme. So we can certainly ask them about how they've addressed it, what the success has been, and then how we can sort of share that wider as an example of good practice. That's a good suggestion, thank you.
I will just say that my grandson the other night said to me, I said, Seb, you've been on that screen now 2 hours, it's time to come off. And he said, Granny, you've been sitting watching your film for nearly 2 hours. Touche.
Okay, Councillor Norman.
Thank you, Chair. You can listen to radio and be on your screen at the same time. I do this very often. Can I just say, just bear with me with a little bit of context here, because Dr. Harney said it wasn't political, this report, and everything's political, but it was certainly not party political, and what I'm going to say is not party political. Just that I'm sorting out my library, if you like, and getting rid of a few books. And one book I had got and hadn't read, which is embarrassing, which was about Agincourt, excellent book. And if I wasn't optimistic, like Henry V, well, it wouldn't have got past Harfleur. So I am optimistic, but I'm also conscious of the national context, and this is referred to in section 6 there, about the context of doing what we can do to try and reduce childhood obesity, is that we're up against it. One of the books that I'm not throwing away from the library is called The Politics of Food by Geoffrey Cannon, written in 1987, refers to the 1980 Education Act, where local authorities were released from the requirement to have nutritional standards in foods. And then in 14th of February 1986, there's a broadcast, the properties of obese children is increasing. This is 1986. And this is worrying, because the evidence is that you become obese, and the longer you have been obese, the more likely you are to develop diabetes and high blood pressures. I mean, there's nothing new here, you see, and it's the national context. The smoking issue, we couldn't have improved the smoking issue if national governments hadn't banned smoking indoors, and various other things like putting the price of smoking up and so on. So, you know, in 1986 there was also a teenage diet report, but we don't seem to make much progress at all. So my question really is about what we can specifically do, and we need feedback on that, because other members have asked that question, what we can do at local level. The other thing is, for example, more exercise in schools. Well, in my experience at schools, it tends to be team sports. Well, more exercise, if you're looking at more intelligent reports than that, it's just about being more active rather than just you see me struggling up the steps and down again every time I come to a meeting. But that's it. I have to be in a team sport to do that. But the walk into school, I was involved in that as chair of the Education Scrutiny Committee here years ago. I remember one school, because I also had a job of looking at schools in the north, which wants to close because of the reduction in pupils. And there's one campaign there with a particular village, I won't name it, but it was the heart of the village being torn out. We got rid of the school. More children were taken out of the village to go to other schools than were actually going to the school within the village. And the reason is obvious, or at least it was to me at the time, is that on the way to work, because it's all about time, which has been referred to on people, the parents take their children, drop off at that school that's more convenient and so on. So it is, time is always a problem there with the walk to school. It's not so much the, I'm going to the trouble of the exercises, you know, you might be
Councillor
spending
Norman,
three-quarters of an hour as opposed to...
can we get to the question, please?
Yeah, well, the question was early on, and this is the context which is leads up to it, which is the point is, what can we specifically do? But don't let's kid ourselves, it's a national issue, it's the national politics that are required to do something here. Whatever government, I say it's not party politics, it's actually getting the government to actually enforce those companies that sell sugar and all those other things, they're the ones that have got to be got at, and it's as limited what we can do. I could say, do you agree? But that would put you in an awkward position, Dr. Harling there, so I'll just say, is it of interest to you?
Yeah, again, I think that speaks to the theme in the report, which is this is going to be difficult. Back in 1412, we could do things by King's decree, couldn't we?
1415.
Oh, 3 years out. And you know, the king could make a command and it would be obeyed. That's not the society we live in now. I think with smoking, probably the single biggest thing that made the difference was the smoking ban in public places. If you look at the rates, they really went off a cliff then. There probably isn't a comparable regulatory step that you could take for obesity, or at least not one that the population would tolerate, I don't think. So I think the government is exploring regulatory solutions, but it's probably, it's doing it quite carefully, I think. So that leaves us locally with what can be done. So I think one thing that we can do is raise awareness of this issue and champion solutions. And all of you as leaders in your own communities have a really big role to play there. And then it's about trying to build local solutions. So small things that work bottom up, where we can really inspire local people to take action that's going to give them a healthier diet and more exercise and tackle this over the long term.
I'll come back briefly just to defend Henry V, because it wasn't just the command that went out. He actually did sell it to his people, to his soldiers, all the rest of it. So I was quite amazed how much effort he put into convincing people this was the right thing to do. That's to say, claim France for his kingdom. And obviously that's what we need to do, try and sell it to people. These are the benefits, this is what's good, and these are the dangers of later life if you don't sort that out. So I'm not again, I just wanted to put the national context in, saying how difficult it is, just emphasise that. But yeah, if you can get back to district and boroughs and get feedback from district and boroughs about what they're able to do, as well as the county itself, that is great. Thank you. Thank you, Chair. Thank you.
Thank you for your lengthy analogies. Is there any other questions? Councillor Edger.
Thank you very much, Chairman. And yeah, on page 43 of the report, it's talking about promoting the walking bus. How is this working and what are we doing to promote it? Because I've got the job of, I'm going around all my schools actually to try and promote this, but I think the problem is finding people that will do it. You know, the people, the parents and that will take charge of these children walking to school. Because as we all know of all the legal requirements and everything. So what are we doing to promote it, please?
So that work sits within the active travel team and the Economy, Infrastructure and Skills Directorate. So not directly with us, but we do work closely with that team. So I've been a volunteer for the walking bus a few years back. So yes, it's a bit of a challenge as a volunteer, but it's really rewarding. So I guess how do we get that information out there, isn't it? That it's actually a really good thing to do. You can get your physical activity minutes in quite easily through doing a walk as the parent as well as the child. So yeah, I will go back to the active travel team and ask the question.
And last question to Councillor Wallins.
Thank you, Chairman. And yeah, it is it's interesting in this committee to have a history lesson and to also learn about a book about food or politics. I didn't know food had political. I didn't know food had political groups, but you know, you learn something new every day. But yeah, just one quick question I want to ask is, ultra-processed foods, such as like frozen pizzas, frozen foods, and so forth, you know, they're very cheap and very quick to cook, if that makes sense. Whereas, you know, prices of like fruit and veg, you know, always going up in price. And if you're from a working class family point of view, or someone that isn't, you know, you had to tighten up the belt due to inflation, for example, you know, looking at fruit and veg and then comparing it to like frozen food, you know, frozen food in a lot of people's eyes would be the way to go. I was just wondering going forward, would we combat it? I know I mentioned about the Healthy Start card and so forth, but what other alternatives would be going forward?
Sorry, I'm not sure I understand the question. Apologies. Would you mind repeating it?
Yes, sorry. In terms of to tackle ultra-processed foods, such as like frozen pizzas, like frozen chicken nuggets and so forth, how would we combat that and get more people to go and eat more fruit and veg? There you go.
So again, I think it's a sort of question with a probably complex answer. I think there's a big role again for schools and education, so that people know what to do with fruit and veg, because I don't think we can necessarily take that for granted. I think there are various schemes like the Healthy Start you've mentioned, but also local schemes as well, which try and promote access to cheap cost fruit and vegetables so that people can actually afford to buy them. And then more information and advice for the public about the choices they're making. You know, when you're making a choice to put cheap food into your mouth, there are consequences of that, and you know, people need to make choices in full knowledge of what the benefits and risks are likely to be. So I think there's a whole range of things. I hope that many of those are probably picked up by the Better Health Staffordshire programme. But if anybody else has ideas, suggestions, please, we're always open to those.
Thank you.
Okay.
Just one question, and Dr. Harney's already got notice of it, which was on figure 7 there. There's the two wards that are quite contrasting there. Is Little Aston and Stonnell and Norton Keynes ward, both quite different, although the Staffordshire Observatory isn't as good as it was, and you can't find the details I used to be able to find on there. But there seemed to be one that was quite different wards, so the obesity seemed to be odd that it was in a very well-off area, Little Aston, if you're planning, you know that, and in Norton Keynes ward there. I'd given notice of the question, or at least he'd given an answer. I just wonder if you'd said a bit more publicly to convince me that it's not just poor people that get fat, in a nutshell.
Yes, so we say in the report that there is this relationship between deprivation and obesity. So on the whole, in more deprived areas, you tend to find higher rates of overweight and obesity. It's not a perfect relationship, though, and so you will always get, I guess you could call them exceptions that prove the rule, which are relatively affluent wards where the rates of obesity are high. And I think the two examples you've raised probably fall into that category.
Okay, thank you. Thank you for your presentation, and I do hope this is a successful plan going forward. And I do hope that everyone does sort of involve themselves in this and actually gives their ideas. I think it's a wonderful thing. We request to receive the action plan associated with the Better Health Staffordshire scheme, if that's okay. Yeah?
Yes, Chair, I wrote down a few points. So there was the the point about clarifying the relationship between underlying medical conditions and obesity. There was a question about increasing the uptake of Healthy Start. Lots of interest in some of the examples, so we can probably create some kind of database of those, can we, to circulate around. The walking bus action, and then we said we'd share the action plan for East Staffordshire, but there is a corresponding action plan for each district and borough, and it'd be quite straightforward for us to share those as well.
Is it okay if I add one on to that? Could I have some information on how we're going to ensure that the services that we're sort of involving in this, how we'll ensure that they'll actually follow this through? So how we...
Okay.
Yeah, is that okay?
Yeah, that's fine.
Okay, thank you. Okay, thank you very much for your presentation. That was wonderful, thank you. And so, next on the agenda is primary care access, pharmacy and social prescribing update. That is from Tracy Cox and Sarah Jeffrey, also Mish as well. They're just exchanging over at the second. So this is the report from the ICB with a presentation.
Good morning, everyone. I'm Sarah Jeffrey. I'm the Director of Primary Care for Staffordshire and Stoke-on-Trent Integrated Care Board. Thank you for inviting us today. I think this is a return visit from January of last year to give you some progress on our access, our general practice access. So general practice, as you know, is the first point of contact for patients and equates to around 80% of contact in the NHS. So it's quite significant. It plays a crucial role in that prevention, early intervention, diagnosis, continuity of care and management of long-term conditions. When we're talking about GP access, we need to understand the context in the appointment. What we have is in terms of appointment availability, what our workforce capacity looks like, and what is digital, what is non-digital, and what our patient experience is actually like overall, and the differing needs within each local community. So there was a national delivery plan for recovering access, which came about in May 2023, and that was to help general practice with the challenges that they face around the patients needing access, keeping pace with the growing demand that we have and how we realign it in the future. So it looked at a number of things: digital access, how we access our GP practice, how we get through on the telephone, for example, the demand versus what's actually available and what that capacity looks like and what our workforce looks like as well. So we developed from that a system-level access improvement plan within the ICB, which came to this committee to be presented back in January 2025. It goes into quite a lot of specific detail around how we want to improve patient access and what mechanisms and interventions we're going to put in place with our general practitioners to support them with supporting our population to get access. So the overview that we're, go on to the next slide. The overview that we're providing here today, it sets out what our current position is. So what does it look like in terms of our patient experience? What are our key challenges and pressures that we face, and what are the pressures not just within the public but equally within our practices themselves? What the actions that we're doing to support them with our local improvement plan, and today we wanted to provide some assurance on how GP access is looking across Staffordshire, how we're addressing it, and highlight the risks and some of the variation that we have, because we recognise there is variance across the GP practices in the way that they operate and the different services that they provide. And as part of this, we will be touching on local pharmacy schemes and some information on social prescribing as well. So a lot of the actions that have been happening to support our GP practices in implementing this modern general practice model is the flexible contact and response options using digital technology, so digital triage, online consultation tools, and improvements in telephony systems. So 100% of our practices have now got cloud-based telephony systems, so that you're not placed in a queue of, 40 people, as you may have experienced in the past. The other changes that have happened more recently is that there is a contract change which came about in October 2025, and that's to support patients having face-to-face contact with clinicians, the telephone and online access, and the introduction of something called the Patient Charter, and that's called You and Your GP. So every practice across the country should now have the Patient Charter on their homepage of their internet web browser, and the guide tells everybody what they can expect from their general practice and how they can help their practice and how their practice can help them, so that they get the absolute best from their experience at their GP practice. So the other thing just to say is that was quite a shift in workforce and new roles that were introduced a number of years ago now. So but more and more has been added. So additional roles in general practice offer more of a skill mix. So now you're likely to see physiotherapists, pharmacists, paramedics, and a number of other key mental health workers as well. There's a number of key roles that now sit in that general practice. So that's to ensure that patients get to the right service to support their needs the first time. So getting it right first time. I think I'm passing over to Tracy now.
Good morning, everyone. My name is Tracy Cox. I'm the Associate Director for Primary Care for Staffordshire and Stoke-on-Trent ICB. I will be bringing in my colleagues, Dr. Mark Stone and Vicky Oxford, throughout the slides, but I will let them introduce themselves as they do come in. I'm going to just take you through just the first few slides, and the first one is what Sarah was just describing, really, around it's really important that we start to measure some of what we are doing here. And actually, the first critical measure for us is about listening to our patients. So what are our patients telling us in terms of the changes that we're making and they're making out, out in general practice? And one of the key, I suppose, measures for us is looking at the National GP Patient Survey. So this is a survey that's commissioned through NHS England on an annual basis. It's just happening at the moment for this current year. So the figures that we've got at the moment are for 2025. Mish, would you just mind just scrolling back? Just in terms of, yes, please. So what we've done here is just done that comparison piece from 2025 compared to 2024 for some of the key indicators. So this is feedback from patients across all of our 141 GP practices. I am really pleased to say that we are starting to see improvements here. And it's even more pleasing that actually we are hovering above national rates and West Midlands rates as well for some of the key indicators. So some of those key indicators I think that you'll be really pleased to see is around patients getting through on the telephone. That has been a real challenge, and we're starting to see the tide turning on that. And that's really important when you think about the context that Sarah's just provided around the cloud-based telephony, changes that we've made. So seeing some of the changes around that and around patients actually accessing their general practice, we're starting to really see the changes and the improvements around that and their overall experience as well. And some of the information that they're finding on the website, you will see that websites are starting to really grow out in general practice now. So I think the important bit here, and Sarah touched on it, is about that variation piece. So we are seeing probably significant variation across our GP practices. So whilst we are seeing averages improve, there is that variation. And that's where the support and intervention piece that we're doing with our GP practices is really important, to target those practices where their patients are saying this, we still haven't got this right. So we are tackling that variation as part of that support and intervention work. So the next slide, thank you, Mish. So the next slide is around GP appointments. And again, I'm really pleased to be able to report to you that we are seeing an increase in GP appointments out in general practice. I think it was up to November, the figures that we're providing here for Staffordshire, there was a delivery of 3.4 million appointments out in general practice in Staffordshire. And that's a 2.3% increase compared to the previous year. Now that sounds really good, really positive. However, we can't keep doing more and more and more appointments, because actually what we have to think about here is how do we use appointments more effectively out in general practice? And that's in the context of the issues around GP recruitment and retention, particularly. You know, we risk stress and burnout out in general practice, and we're at risk of kind of over-medicalising people as well. And going back to what Sarah said, this is about getting people to the right place at the right time with the right professional. So it's really important that we look at GP practice appointments in that whole context. Just in terms of as well, around the capacity piece, this is about making sure that patients can be seen quickly where they need to be seen quickly. This is about active signposting, and we'll talk a little bit about community pharmacy and the services that they're offering to support general practice in terms of that kind of diverting some of that activity away that does not need to be seen in general practice. And again, it's about offering a service to patients that is personalised and that is equitable where, you know, in terms of where they do need to be seen. So that's the kind of approach in terms of GP appointments. I don't know, Mark, if you want to say anything in addition here in terms of the context around particularly the GP recruitment and retention piece and appointments in general.
Thank you. I'm Dr. Mark Stone. I'm a GP in Staffordshire and also ICB clinical lead. I mean, with GP appointments, as Tracy's alluded to, it's increasing the number of appointments and increasing access, although we can't manage that in the longer term, so we need to look at how we manage and get effective value from the appointments that we provide to do so. And it's obviously looking at how we can promote, as we've alluded to earlier, around the prevention agenda to reduce the demand that we see. So obviously reducing weight, reducing alcohol is really important, and the group has heard from a previous presentation around the importance of that. We've got increasing pressures on our GPs through the increasing roles of using other roles. They need supervision, which does impact on how GPs can provide support to patients, because there's obviously the role around the GP is changing around the work that they're doing. We're doing a lot of work around trying to retain and maintain our GPs. There's also a scheme to employ newly qualified GPs to try and increase the numbers around, which is through an additional roles reimbursement scheme, which is a similar scheme which has employed the other roles in general practice, which is the mental health practitioners, the physiotherapists and the pharmacists that Sarah alluded to earlier. So overall, I think it's really important that we need to start looking at how we effectively use appointments and how the general public have responsibilities around how do we use our services effectively and improve that. It's important that we improve access. We also need to look at improving continuity as well for patients. There's a lot of factors around how we utilise services effectively to get the best value from what we're doing.
Thank you, Mark. So in addition to this, and in the context of what I've just described about the more and more piece, actually we do need to recognise that winter can be a very, very challenging time for our health and care system. So in response to that and to support the winter period, and that we see that increased demand and complexity, we've actually commissioned winter hubs out in general practice. And they've been established to see the same day or next day urgent for ambulatory patients who can be seen quickly when they are acutely unwell. And there are 5 of those hubs that are in Staffordshire and Stoke-on-Trent. And these work for patients who are actually willing and able to travel to maybe a different location than their current GP practice to be seen for that acute problem. So as I've said, 5 have been established. They are currently running at the moment, and they will be running up until March, and they are going to be delivering around 46,000 additional appointments during this winter period. So this helps in terms of releasing that kind of further capacity out in general practice to enable GPs and general practice to focus on continuity of care for patients that do really need to be seen within their own general practice. So, for example, patients that have complex needs, vulnerable patients, etc. And due to the peaks that we see in the demand during winter, we expect that many of these appointments will be delivered in January, February time to recognise that that's when the peaks are actually seen out in the system. However, the winter hubs do have the opportunity to flex those appointments if they do need to, based on those peaks and kind of trends that we're seeing. Activity will be taking place, or is taking place, between 8 a.m. and 8 p.m. And these are appointments that are booked directly through the GP practice. So patients will be triaged as they come into the GP practice and will be deemed needing an appointment within one of those hubs if they can be seen in those hubs and if they can travel to those hubs. So that's the winter appointments. I'm now going to move us on to Pharmacy First, and this is a really interesting bit because this really does support out in general practice. This supports that kind of shift towards patients being seen at the right time, in the right place, with the right professional, and pharmacies can really help and support that approach. So the Pharmacy First scheme, for those of you that don't know what that is, I just thought it would be helpful just to highlight this. It was an initiative that was launched back in January 2024, and it's allowing patients in England to have treatment and be seen by a community pharmacist for 7 common conditions. So those seven common conditions, and there is criteria within these conditions, but I won't go into the detail around that. But the sinusitis, sore throat, earache, impetigo, infected insect bites, shingles, and uncomplicated UTIs in women. And so these are patients that can be directly seen by a community pharmacist, don't need to be seen by their GP, and can include a prescription only medicine like antibiotics or antivirals, for example. And that helps to ease that GP workload, as we've described, and also improve access to care for patients that can be seen for one of those conditions. Interestingly, we've seen some figures from the West Midlands perspective. So this isn't just for Staffordshire, but within the West Midlands, 579,000 Pharmacy First consultations have taken place for the first 6 months of this financial period. So that was April up to November. And that has saved approximately 96,000 hours of, if you think about 10-minute appointments, that is really significant, and it's really significant for general practice. In addition to this, and what you'll also see on the slides, is there are some additional consultations that patients can book. So there are consultations for oral contraceptives and for blood pressure checks as well. And it's really, and you'll see on the slides there, you'll really see those increases of patient contacts accessing pharmacies for these particular conditions. And again, I'm just going to quote some figures again from a West Midlands perspective, but I think it really does help to put it into context. So in terms of blood pressure checks, there were 301,000 checks made within 6 months of the financial year. And 4% of those checks confirmed that those patients had high blood pressure. Now, if we assume that 5 years of compliance to management plans for those high blood pressures, so those patients comply with that, that would save around 210 strokes, 141 heart attacks, and ultimately 112 deaths. Again, that's really significant, and I think that really kind of focuses our attention on why that's really important and why it's really important for patients to be able to access checks in that way. I'm now going to hand over to Vicky just to talk a little bit about the support around pharmacies and general practice and that relationship, but also the pilot as well. So, Vicky, I'll hand over to you.
Okay. Hello, I'm Vicky Oxford and I'm the Primary Care Programme Lead for Staffordshire and Stoke-on-Trent ICB. So as Tracy has said, there's an awful lot that's going on in community pharmacy. And we've got an awful lot going on outside the common conditions around the blood pressure monitoring and also the oral contraceptives. In terms of the activities that we've got going on, we very much try to support our pharmacists and also our GP practices and our patients in terms of awareness of the services that are available at the pharmacy. So we have 3 primary care network engagement leads focusing specifically on the pharmacy and the GP practice and the relationships between the two, because this very much is part of the work that we've got going on to start developing our neighbourhood health models, because the pharmacies are very much part of the neighbourhoods in which our patients are residents and which our GP practices and the pharmacies are working. So we're looking at how we can support those referrals to the 7 clinical pathways, but also establish good working relationships and models around all the contraceptive services and the blood pressure monitoring and any new conditions that may be added in the future to that particular service. So we've been running local communication campaigns, which have run throughout the year. We've just finished a communication campaign, and we're looking at the outputs of those campaigns to look at how we can then support further communications and awareness amongst our patient population. And at the moment, particularly around impetigo and UTIs, so we're looking at the next phase of those. Our pharmacists have been attending winter-ready events, so our primary care networks, which are groupings of GP practices and geographical locations, have been supported by our pharmacists at those particular events. They've been putting them on to raise awareness amongst our patient population of different services that can support them during the winter, but also throughout the calendar year. We've also been working with local authorities around promoting the service through schools and education establishments, because a lot of these are things that can be dealt with in a pharmaceutical setting without having to go to the GP practice. So in terms of our appointments that have been going on through the pharmacy schemes, in the West Midlands, as Tracy said, we've had 579 consultations taking place, and the assumption is that those 10-minute appointments saved, which equates to 96,000 hours, and that's 96,000 hours across the West Midlands, and then obviously our share within Staffordshire and Stoke-on-Trent that can be utilised within our practices to see other patients and to provide that continuity of care perspective. Some of the other schemes that we've also got going on are the community pharmacy schemes around the Pathfinder pilots. So these were NHS England initiated schemes. It's a programme to test and evaluate how community pharmacists who are qualified independent prescribers can deliver NHS commissioned clinical services directly from those community pharmacies. So this is to prepare the NHS for the fact that from September 2026, all newly qualified pharmacists will graduate as independent prescribers. So it's very much looking at how we can increase that capacity within primary care, which includes that pharmacy provision, improving the patient access to treatment, reducing the pressure on GP and urgent care centres, and then inform the future national commissioning framework for community pharmacy and the clinical services that do include prescribing. So it's quite an innovative programme. So our ICB went live in February 2024, and the Pathfinder programme it came to an end at the end of December, but we have got a continuation of that programme locally. So we had 5 community pharmacy Pathfinder sites across Staffordshire and Stoke-on-Trent, 4 within Staffordshire and 1 within Stoke-on-Trent. And they tested a range of clinical models, which included hypertension, lipid management, anticoagulation, minor illnesses, antidepressants, and prescription management and synchronisation. So they can assess the patients, diagnose where appropriate, they can prescribe, stop or change medicines and complete episodes of care without having to refer back to a GP or to refer on to other care providers for tests or further diagnosis. So we've had quite a lot of success in terms of this programme. So across those sites, we've delivered 9,000 consultations, which has released approximately 1,500 clinical hours, which again is equivalent to 200 GP working days, which has meant that our GP practices have been able to see other patients because our pharmacists have been supporting with the management of those particular cohorts of patients. And those consultations were delivered through a mixed model. So there was 44% of those were face-to-face, but there was also 48% via the telephone and 2% virtual. So the prescribing activity in those models was significant, and 64% of those consultations did result in medications being issued. So we can see, the impact that it's actually been having. And that included 4,147 new medications and 463 deprescriptions where it was deemed that patients didn't actually need to continue with those particular medications. So they manage both sides of the coin from a medications perspective.
Thank you. And then on to our last slide, which is around social prescribing. So this is through the lens of primary care, but, social prescribing is a much bigger, much wider programme, as I'll describe. So in general practice, and I think Mark touched on this, primary care networks do have a pot of funding to employ additional roles, and the social prescribing link worker is actually one of those additional roles. And they help, so a social prescribing link worker helps to connect people to community support to meet practical, social or emotional needs. And by that, we mean things like loneliness. They maybe have issues around debt or financial problems, housing problems. And it's kind of then that impact on their health. And it helps them to improve their own well-being. It helps to improve their confidence, take control of their own lives by connecting them to activities, maybe some support groups, or maybe some other services. So for Staffordshire, and I'm just thinking specifically here for Staffordshire primary care networks, they actually employ nearly 40 whole-time equivalent social prescribing link workers now. So they are out in general practice doing this role. And many of those roles are actually employed through Support Staffordshire. So there's really that close link and relationship between general practice and the voluntary sector as well. Now, we are able to put, you'll see on the slide there, we are able to pull some themes around that, and we do have case studies that kind of describe where patients have really felt that impact on social prescribing link workers. One of the things that we are looking at the moment, and primary care will be part of this, is, so what does that mean then for the people themselves, so for the patient outcomes, and what does it mean for the system? So we need to look at that quantitative evidence around and track patients in terms of when they've had a social prescribing intervention, which is why this is much bigger and much wider than primary care, but primary care absolutely needs to be part of that conversation and part of working through that. Some of the national evidence is showing impact on reducing A&E attendances and also multiple GP appointments as well, which is really pleasing to see. But I think from a local perspective, we really want to understand what social prescribing link workers are having on our patients, our patient outcomes and access. I think that was everything I wanted to say in terms of the slides today, recognising that is a lot of information, and I suppose there's three key bits to what we've described today. There's the very big bit around GP access and all of the support and interventions that we are putting into place, recognising the variation. We have the community pharmacy and the pharmacy first schemes that are really supporting that access piece as well. And then we've added some information around social prescribing link workers. Mark, did you want to add anything further before we pass back to Sarah?
I think overall it's a very good summary. I think obviously with GP access we have to sort of reflect back on that there's a 2.3% increase in appointments, but that's despite all the other interventions that have been undertaken that we've heard with social prescribing, with pharmacy first and all the other interventions, the Winter Pressures Hub. So it is reflecting back on the significant demands that we are seeing in general practice. I think the unwanted variations is something that we significantly need to work on. We need to ensure that patients in different areas of the county have fair and equal access to GP services. Sometimes, occasionally, variation is important to deal with a particular subset of population and a group that the practice may be dealing with, but that's an exception rather than than a rule. I think GP access, I mean, obviously for patients, it is now a little bit more complex. It's now the sort of program around trying to get patients to the right place at the right time with the right clinician, because the number of clinicians and the variation in the clinicians in general practice has significantly changed over the last 5 years, and there's ongoing programs to help around that. It's obviously difficult for patients to know whether do they do a telephone consultation, do you do it online, do you walk in? All these are complications and things that we need to help patients through, being able to access the system in a fair and effective way so they can get the care they need essentially at the right time. And this is all work that's ongoing at the moment.
I think, thank you, Chair. It's probably better to open to questions, because I'm sure there's going to be a few.
Okay, thank you for that great report. Okay, so we're going to go straight into questions now. So, Councillor Norman, and can we keep it to the question?
Yeah, I see what you did there. Thank you very much, Chair. I appreciate that. It's only brief. One is that I look forward to seeing the slides so I can read what was put on display. I'd like to have got them beforehand, but there you are. The straightforward question is really, what are the two main barriers for further success, because you have been successful, other than the recruitment of staff in pharmacy? Because I think there's some great successes there, I think, over that 6 months. So hopefully you can send the data to us, or links to the data that's been referred to. And my question really is, what are the two main barriers that, I could say three, but I'm saying two, that we might be able to look into further. Thank you. Thank you, Chair.
Sorry, barriers to what?
To further success. I mean, one of them is recruitment, clearly, in pharmacies. But if there are any others, you don't have to make them up if there aren't any. It's just making progress. But I just wondered if there were any issues we could explore further than you see.
I think there are a number of barriers to success, or making this better, and it's not just recruitment and retention. We talk about online services, digital technologies, the utilisation of such, and we really need support in supporting our general public and population to have access to things like the NHS app, so that they can take control themselves, but equally manage their own medical records, be able to see their results, and get access to their prescription requests and things like that. So, I know 95% of the population do have a smartphone, but then utilisation is very mixed, isn't it? So you talked earlier about children being glued to their phone. A lot of people talk about the older population not being able to utilise technology. I think that's a bit of a myth that I know my mum uses her phone to, but health literacy in general, we are doing a big piece of work on health literacy and understanding the language within health. And we're doing that, we just kick-started that as a system so that we can support our communities, not just to get access to the information they need, but to be able to actually understand it as well.
Can I just add something to that as well? I think we talked a little bit about our communication plan. Communication is where it really is, isn't it? That's at the heart of everybody understanding what we're trying to do, and the biggest bit here is taking our patients with us on this journey. Some of the work that we've been doing, I will hand over to Mark in a minute, just around the behavioural change piece, because that's important from a patient and a workforce perspective. But I think, helping us with communication, we've started to make some links around some of the work that's happening within our people team around using volunteers to support patients around, using things through their smartphone. So there's all of these different connections that we're trying to make to kind of broaden that communication and behavioural change piece. So that will link into what Mark can hopefully describe.
Thank you, Tracy. I mean, we have been working on a sort of behavioural change work around trying to help support service users of general practice to be able to understand the changes and be able to effectively sort of negotiate the changes better, because obviously these changes came in through COVID, and obviously communication at that point in time was around other matters at that point in time. But it's important, you know, the behavioural change programme has looked at putting communications out there around the different roles and what patients can expect from those different roles and how they may be able to support. And in respects to some of my colleagues, seeing a GP for a medication review may actually be done better by a pharmacist who's actually trained in that area. So we've got to use the skills of those staff in the most effective way to provide the best care for patients. So it's around sort of trying to help patients negotiate. So when they contact the practice, there's changes within the reception staff. They're more helping to try and navigate patients through the system. So they're not being nosy of the problem when they're phoning up and actually asking what the problem is. They're trying to help negotiate patients through the system and be their advocate at that point in time. And it's changing those perceptions around what those particular staff are trying to do. So it is trying to help patients negotiate the system, which has become more complicated. You go back to general practice 10, 15 years ago, it was just GPs, few nurses and receptionists. If I look at my own practice, we employ nearly over 35 people, and that's as a practice. Then we've got the additional staff that come in through our PCM, which is where a lot of these staff come through, and there's a lot more different professions, and it's helping patients to negotiate that. So when they phone up, actually I do need to see the physiotherapist or the pharmacist rather than asking to see the GP to help them negotiate that process. So there's an ongoing programme around how we best help facilitate patients to recognise how to use the system in a better and more effective way to help their care.
Thank you. Councillor, do you have a follow-up?
Only just briefly to say that with older people, yeah, there are fewer and fewer now that aren't using smartphones and have access, but there are still some. We have a friend who, for her 100th birthday, arrived on the back of a Harley Davidson at her own party, and she's still going, and she took great pleasure in sending us text messages every now and again, but there still are people there that can't do that, so you obviously can never forget that. But the other thing was, yeah, the NHS app. I did use it last night, in fact, to order my prescription again. In fact, you go onto the GP's website and they sort of put you off, making it more complicated, hinting that you should use the NHS app, which I do on the PC rather than the smartphone. So there is every time you do anything like that, NHS app is promoted, and I understand that, and that's excellent. That's all. Thank you, Chair.
Okay, thank you. Councillor Parton.
Thank you for your presentation. It's quite informative. A couple of points really. The first point is he's sending people to the pharmacies for certain things. But can you tell me, is there a list of pharmacies that do blood pressure monitoring? Because I've tried to go to a couple of them and they said we don't do that service here. And it's quite important. As you say in your presentation, it needs to be picked up on. And the second point is mental health support in one of the slides. Have you ever tried trying to get mental health support? And it's quite hard sometimes to get that support, especially in the community as well. So those points need to be looked at if that's okay. Thank you very much.
Yes, we can get a list of those pharmacies, and I'm sure that's available online, but I will look to Vicky just to double check that. And in terms of mental health support, absolutely recognise the importance of mental health support. I sat in on a presentation last Thursday where our clinical director for mental health, learning disabilities and autism did a presentation around the 10-year plan and the actions that are going to be taken over the next few years, really linked to the work that we're doing around access and support for patients with mental health problems. So we are absolutely linked into that area of work, and I'm sure that they would come and describe some of that work to this committee if needed.
Thank you very much. Thank you.
Okay, thank you. Is there any follow-ups to that question? Councillor Wallins.
Thank you, Chair. And yeah, thank you for the report as well. One of the things I'd like to highlight on is, it says in the report pack, the online consultations available in 141 practices. I was wondering how come it hasn't been rolled out to every single GP practice in Staffordshire?
It has now been rolled out to all practices. Now, in October, it became a contractual obligation to provide online consultations or triage. So it's now across all practices, actually across the country.
Okay, thank you for that. And the second one is, in terms of, especially more like lack of GPs, especially when new builds have been developed, would it be possible to pressure on these developers, such as like Bloor Homes, Barrow Homes, Redrow Homes, to put more GPs or local doctors in place and so forth?
I mean, we can't do anything about the planning of new homes. Some of these are huge developments that have a significant impact on health, education and everything else. What I can say is we work very, very closely with the local authority around any planning applications that go in areas, wherever they are, and we look at the health implications of that and whether our GP practices can cope with the demand that may come in, whether there's any opportunity for estate to be expanded or workforce to be expanded. So we always have a plan in mind when we're working with the local authority on any planning developments.
Yeah, because I know one particular case, especially in Burntwood, is the health centre that's, well, it's going to be built at some point, to my knowledge. But I know there's a couple of housing applications in place, such as like Coulter Lane and so forth. But yeah, thank you for that. And the last question I've got, going back into more the history aspect of things, but I know back then people used home remedies, and so forth, picking berries, leaves, and so forth. But I'm not saying people to go out. Mushrooms. Yeah, mushrooms as well. I'm not saying that you should encourage people to go out and pick leaves or mushrooms and so forth. But would it be possible to encourage people to use home remedies more? To ease the burden of GPs and pharmacies?
I think it's very important. I think it sort of also falls into the health literature and people's understanding around how to manage their health and what to do. And it goes back to sort of education elements at school as well. I think you're absolutely right. We do need patients to be able to care for self-limiting conditions. If you've got a mild flu, you can see your pharmacist. It is paracetamol, it's fluids and bits and pieces from that. These conditions where there's viral, which there's very little that I can do unless patients have other medical complications. You've got to potentially ride those conditions out. So it is really important that patients are able to, and citizens are able to self-care, and we need to be able to do that to take the pressure off general practice, to be able to focus on those patients that really benefit from seeing a GP. So absolutely, I think it's a real importance of being able to use homely remedies or self-remedies to be able to care, and there is advice from pharmacists and other professionals out there to help patients negotiate that process.
That's fantastic. Thank you for that. Thanks, Chairman.
Thank you. Councillor Hood.
Thank you, Chairman. I'm quite often at my doctor's and other doctors because I take elderly people who, through a volunteer scheme. And the last visit that I did, once again, I've raised this time and time again. I took a notebook with me and I wrote down the personal details of 5 people who gave their date of birth, their name and their address to the receptionist, which to me is a gross breach of GDPR. The reason for this was because their automatic booking in system was broken. I went through with the elderly lady to see 2 charming trainee doctors. And I said, as I was going out, I'll just leave this with you so you can destroy it. These are the personal details of people that your receptionist is asking these questions. And because there's now this ludicrous, I can only call it a loudspeaker inside the glass screen, everyone can clearly hear what is being asked and what is being replied. And one of these young trainee doctors said to me, "Oh, it's like that at Royal Stoke," as though that excused the fact that that is taking place in the doctor's surgeries still. And over the years on this committee, I have raised it time and time again. This shouldn't be happening. But I must say that the doctor's surgeries I go to, the staff are charming, they're very professional. But then we get to the next stage, the prescription stage. The amount of people who call me and say, "Jill, please, what can I do about my prescription?" Yet again, they've not sent the complete prescription. I have no idea why that happens. I will say, because I've got those two very important points to raise with you, had you have done your presentation in 3 stages, for me personally, it would have been a lot easier to digest and remember. I've got copious notes here on my little bit of paper, because I came without my notebook, my trusty notebook. I have to say to you that on my list of ones to be avoided, which aren't many, personally for me, doctors' surgeries, pharmacists, let's go on to the pharmacists. In my division, we have 3 pharmacies. Never do I go past those pharmacies when there isn't a queue out of the door. There's only one pharmacy who can adequately house the bags of prescription medicines. One of the pharmacies is so tiny that there are shelves, copious amounts of bags of prescription medicines. The other one in my high street is exactly the same. The staff manage so well, they are incredible. And the pharmacist, I've never heard any of the pharmacists refuse as you say, blood pressure, an earache, a child, can you see? Absolutely magical, that is definitely working. Social prescribing, I'm a volunteer in a number of fields. I have no awareness of social prescribing. We have many, many phone calls at Age Concern. I'm a town councillor as well. We have many, many phone calls for help through the town council, the borough council, and as a county councillor. So I think that needs to be publicised more widely. But yet again, we come back to the fact we do not have enough volunteers to run these services. Since COVID, when we had the massive influx, we no longer have the volunteers. So possibly there are some questions there, the doctor's surgery and the breaches of confidence, that definitely needs sorting. Pharmacies, you're going to say to me, well, it's up to the individual ones to get the premises big enough, which is almost impossible. But I thank you for all your work today, and it's been really interesting. Thank you, Chairman.
Accept absolutely that there was quite a lot to take in, and if the committee wants further updates and wants it breaking down and us to come on a specific item, then clearly we'd be more than happy to come along and do that with you. In terms of the what you raised around the practice and the kind of rules around GP, you know, the confidentiality and tannoys, and I would say to pick that up with the practice manager directly and raise your concerns. You don't see that in all GP practices, so I wonder whether that's a consequence of leaving in windows and things that that have been there since COVID, to protect, you know, conditions, etc., coming through screens. So I would certainly raise that with the practice manager, because you're absolutely right, there should not be breaking confidentiality like that. I will come on to your other things, but I don't know whether Mark wants to come in at that point around your own practice, whether there's something around. Yeah.
Yeah, I mean, I agree that there should be a distance around that. You know, you should be maintaining patient confidentiality. and it's not acceptable from that point of view. And there needs to be a way of looking at how that is changed. From our practice, you know, obviously patients come in and it's trying to maintain a reasonable distance away, so those conversations can be done in private. We're lucky we have a slightly quieter area that we can take patients over to. Obviously, the difficulty in some practices, they have very tiny waiting rooms, and it's very difficult around the facilities that they've got. But that doesn't excuse patient confidentiality. You may have given names and addresses. They may have talked about other conditions. They may have talked about other bits and pieces that they may, you know, that may need to be expressed to receptionists. And again, it's not fair on that patient or even the other patients in the waiting room to hear that information. So I think it's something that does need to be addressed, and whether it's a communication that we address across all practices to be wary of confidentiality around reception. So rather than focus, obviously there's an element with that particular practice that may need to be picked up, but it's something that we possibly could address across all 141 practices to highlight that, you know, it's really important at a receptionist level respects confidentiality.
It's not just names and addresses that are given out. We'll have it delivered for you Tuesday. Oh, I go out all day Tuesday. There's nobody in on a Tuesday. Straight away. Thank you for that. I do report it to the patient board time and time again. How it's dealt with, I don't know. But thank you for that. Thank you very much. Thank you, Chairman.
Okay, Councillor Greatorex.
Thank you, Chairman. Before I go into the detail, I need to mention a couple of things that unfortunately have been tangentially referred to by Councillor Norman and also Councillor Hood, and that's the way that we receive these ICB reports. I've mentioned it before. It's very useful to have information that we can read before the meeting, and what we've had is a 3-page report, and it's very bald in the way it's presented. It refers to the paper provides an update on the key metrics, and it shows the number of appointments is an increase of 2.3% against the same time period last year. The slide that you put up, or we had put up, I couldn't read, and I'm fairly near a screen. There were some blackened red or orange bars. I couldn't see much difference between them. I couldn't see any date reference. I couldn't see any scale. I couldn't see any labels. So the slide was, you know, the difference between the price of egg and cheese, you know, as far as I can see. Not really much point in having the slide, but it's a good news story. And the point of having this overview and scrutiny committee sit is so that there are things that are happening with the ICB which we want to be able to campaign with, you know, we want to know about. We want to be able to communicate with our residents and say things are happening. You know, there is a good news story here. 2.3% more appointments than there were last year. Now, that bold statement, we need to be able to say, well, it's not happening in my surgery. So is it a national figure? Is it local figure? Does it cover Staffordshire? What's the difference between Staffordshire and the rest? These are the sort of questions that we would probably want to ask had we had the slide beforehand. And the same thing, and Councillor Hood's mentioned this, the same thing when you've got 3 subjects, and there are 3 separate subjects, there could have been 3 agenda items. We need to have more information beforehand so that we can prepare to ask the right pertinent questions to help us get more information, to be your friend, to be your critical friend, advisory body that can help in terms of putting the information together. The slide, unfortunately, is lost. And Councillor Norman said it'd be good to see the slide. Yes, it will be. Probably be able to see the labels and see what it represents. But it's gone as far as this meeting is concerned. So there's a good news story, but again, I don't know whether the 2.3 is across the national piece because you said it's a comparison up to November. I don't know whether Staffordshire's consistent with that or any different. And similarly with things like the Pharmacy First, it's great that pharmacies are taking on these 7 ailments and dealing with that, because that's obviously, you gave the example that the number of hours, I think it was 96,000 hours of pharmacy assistance. That's 96,000 hours that have been saved from potentially GPs and A&E personnel providing, so that's good news. But again, it would be useful to have more information. We can actually help pass this information on. You know, we speak to residents, we speak to district and borough equivalent bodies, and we can help with that communication. And similarly with the social prescribing, if there are 40 people, I've never come across one of them. So again, it would be useful to have some more information about how that's operating, where it's operating. Have you got more strength in certain parts of the region, certain parts of the county? What are the good news stories? Where is it working? What should we be telling our public to look out for? Because we want to help. We want to help more people go to pharmacies. We want more people to go to social prescribers. And we can't if you don't tell us the information.
Can I just interject in here? I fully agree with your comments. I myself had to download your reports from 24-25, which I have here, obviously to understand where you were sort of going with this, which I was looking at the weekend, which didn't really have much of a context. But if you'd like to answer Councillor Greatrix's comments, that would be great, thank you.
So the slides, I believe, were shared, were they not? Because they've come with my papers. They've come with my papers. The intention was that the slides were supposed to be available to you all ahead of the meeting. So that was the intention. But accepting that, if you're saying that there isn't enough detail within the report, then we can increase the level of detail within the reports. The intention today was because it was an update on that huge report that you've seen previously a year ago. We didn't want to then submit that again for you to have to read the whole thing. The idea was that the slides presented an overview of the successes that we'd made since that report was first initially drafted. But I do accept if you need more further information, then we can include that within the paper as well, and we can quite easily take that away and make sure that we improve for next time. That isn't a problem at all. And we also do really appreciate your support, and actions that we can take away from today are elements of what you've picked up, like social prescribing and making sure that, you know, the information is there to our councillors as well in the committee.
Sorry.
I was just going to pick up the bit around the social prescribing and a bit of the history around that to give a bit of context, if that's okay. So you obviously may be aware of primary care networks where GPs are working together in groups, and if I recall, there's approximately 40 in the Staffordshire region. Part of their requirement, which you've heard me talk to, which is this additional roles reimbursement scheme, which is additional money for additional roles, each PCN had to employ at least one social prescriber. So in each PCN, there is at least one in each of those groups. So if I take my own, because I'm the PCN, so if I take my own PCN that I'm a member of, it's the full practice, which is Stafford Town, we actually have 2 social prescribers within our PCM, and they are there, and it's up to obviously how the PCNs advertise out how patients can book in and interact with those, and they are critical. We have found, and with our own PCM, they are critical members of staff to try and help move patients along. We know about the social determinants of health. It's really important. Housing, benefits, loneliness are all significant problems. And as a GP, I haven't always got the ability and time to help people negotiate the complex benefit system. And these social prescribers often have half an hour, 45 minutes with patients, which is an absolute godsend to help them move them forward.
Yeah, if I can come back, Chairman. We've had an election since this time last year, so not many people around from this time last year are still around, so that's something to bear in mind. I'll probably not get thanked by Zach, but if you were to send information through, Zach can decide what we need to see or not see, because he's aware of what we've had previously. And in terms of social prescribing, it's good that you've got some anecdotes, but they're the sort of things we need to know to be able to communicate on, because it's an ethereal thing that we can't really understand without having seen it. So the more we see of it operating with anecdotes, the better.
Councillor Brown.
Thank you, Chair. Well, I don't know where to begin. I've got 2 pages of questions. I'm really concerned, and I have to echo some of the things that have gone on. We have 3 subjects, and each subject we should have been able to overview and scrutinise. I do feel there's a lack of that today, and I'm going to be very brief, but I have a lot of questions to ask, and I would like a reply, a written reply, please. I think there's complete lack of detail, and I do not want to be negative when this morning seems to be all about success. But I hope by the end of what I've just got to say, people will understand where I'm coming from, what I'm picking up, and also things that I've picked up at the last meeting of the East Staffordshire Borough Council Health and Wellbeing meeting. They're in no particular order because I have been writing and scribbling. I'll be brief and I'll be as quick as I can. In November 25, at this meeting, I asked for details on the 46,000 extra appointments. Where, how, and what timescales? I don't feel we've got the detail to understand. And we need to know for Staffordshire and for Stoke-on-Trent. We don't want West Midlands figures. We were given West Midlands figures when it came to the ambulance, and we need to understand, and if we can have it broken down to our own boroughs and town councils. For instance, I know, for example, the East Staffordshire Borough Council want to know what is happening in their area. The next thing is, what is the volume of patients using pharmacy services rather than GP? I know you've touched on the 49,000 hours, but that was West Midlands. We'd like to know for Staffordshire, and if possible for East Staffordshire, please. I'll jump ahead again. There's a big one I want to come back to on governance, but I will come to that in just a minute. Urgent access hubs. 46,154 additional general practice appointments up to March 2026. What was the actual time frame? When did they start? That brings down to 5 community hubs, 9,230, 200 appointments per week, 100 appointments per day, if that was a Monday till Friday. So Sir Robert Peel is one of them. So how does that work? Who's doing them? Or are these people who are being sent to the minor injuries units who are working tirelessly and at great, it's not a word of difficulty. They're working so hard, and I do think they're being very successful. But we need to know the detail, because it's very easy giving us these lovely figures, and it looks all so successful. But on the ground, what's happening? And actually, who is doing these appointments? This 8 till 8 p.m, you say, booked via GP practice, and the appointments at the hub. As I say, are they doctored? What skill mix they are? I'll be brief. I've mentioned Pharmacy First, 96,000 hours, West Midlands. Please, could we have the figures for Staffordshire, Stoke-on-Trent, and East Staffordshire Borough Council? And going forward, please, can we have these figures broken down? Social prescribing. I'm really concerned. On the TV the other day, people lying in beds in the corridor. One lady, for example, elderly, she was dehydrated and had an infection. There's a cost of having someone in the community visiting elderly people to see, are they drinking? If someone comes in when they're dehydrated, it's because possibly they've got no one keeping an eye on them, no one helping them with food, no one helping with them drinks. And the infection to begin with could have been treated at home. But it's got so bad, with a double whammy like that, it's taking an ambulance and it's taking them into hospital and it's taking a bed. So I do feel that that's a huge area where if volunteers are available, that'd be great, but you've got DBS checks, all this, but there's a cost to have a...
Councillor Brown, sorry to cut you off there. I just wanted to say that can we be a little bit more respectful in the way we speak to the officers?
Oh, okay, yeah.
And if you do want any follow-up on any figures,
yeah,
can you email that to me so that
yes,
I can forward those
I'll crack
to
on
the
then.
officers?
Yes,
Is
Chair.
that okay?
Sorry, do I sound disrespectful? It wasn't meant to be. I've just got quite a lot to get through. Am I disrespectful? Do I sound disrespectful? Do I sound disrespectful? No? No, I'm making a point here. I'm making a point. Right then, so I will be brief again, and I just want to bring to the letters. So it was raised at the Staffordshire Borough Council Wellbeing and Health and Wellbeing Committee that there's a lot of people who aren't accessing social media and apps, and the letters at UHDB are about to stop. Appointment letters and contact. And yes, please, could we really, we need the detail, and we need to know what is happening to these people, otherwise these people are going to be lost. The final one I do want to mention, confidentiality, I agree, and I think it's wider than just one surgery. I think it's everywhere. People are standing at pharmacy receptions and they're being asked for their name and their address, and there's a queue behind, and it's everywhere. Same at hospital receptions. It's across the board, and it's something I've always been hugely aware of, and I think it's disappointed. And the last thing I would like to bring up is the diagnostic success of having prescribers, pharmacy prescribers, and all these other different skill mixes, and what is the diagnostic success of people getting treatments and getting, shall we say, onward professional advice and diagnosis of things that are bigger than just, so a chest infection might be a leading thing to something else. And is there an audit and scrutiny of these other professionals, whether they be in GPs or whether they be in hubs? And obviously, I'm the first to put my hand up if I get something wrong. And if my tone has been wrong this morning, I apologise. It certainly wasn't meant. And I think it's disappointing that my enthusiasm for the subject has been taken the wrong way. Thank you very much.
Thank you, Councillor Brown, for that enthusiastic questioning. If you'd like to come back.
I've taken a note of those questions, so would you like us to take those away and do that formal response to those and not do that now?
Yes, I think that would be better, be able to get more context into those and be able to feed it back. Okay, thank you. Is there anything else you'd like to know?
I'm just really interested. Obviously, there was a bit of a nod about the last question about overviewing scrutiny. I think, could we have an answer on that, please, now? Thank you. Or some sort of answer, please.
Was that regarding the additional roles?
The skill mix in GP surgeries and the pharmacy, because I am aware where two pharmacies gave someone different advice with a blood test that was very, very insignificantly changed. So I'm aware of, and I think the overview and scrutiny and governance is a huge aspect and it's never discussed very much. So thank you very much. And again, apologies for my enthusiasm.
Thank you. Mark, can I hand over to you in terms of the governance piece for the additional roles? Is that okay?
Yeah, so for additional roles, and that's why I sort of tried to allude earlier in my conversation, the role of the GP is changing, because I spend a lot of time overseeing and reviewing the work of other professionals within our practice. So I will give an example from my own PCN, is that each practice has a delegated GP for the day that will provide oversight and support for each of the individual clinicians that aren't GPs to gain that advice and support, so patients get the adequate support. They also have a designated GP that acts as their sort of mentor and support from that point of view. So that's what we've done within our own PCM. But I agree that all professionals should have a mentor and other clinical support to review the work and activity that they're undertaking, to ensure, you know, if they're seeing a patient on the day and it's above their competencies, that they are able to speak to a, in our case it's referred to as the duty doctor. They can speak to the duty doctor to gain the support. That duty doctor may come in and review that patient to provide that support and over. So it's really important to have that clinical oversight and support for all those additional roles that now exist in general practice. And as I alluded to, the only unfortunate thing is it then takes me away from actually seeing patients myself, because I'm now reviewing patients from that point of view. So that's why I'd say that the role of the GP has changed, similar to what happens in hospitals with consultants supporting their juniors. It's a similar sort of activity that we're undertaking within practice and across our PCM. From a pharmacy perspective, it's probably out of my remit to speak about, from a pharmacy first, what processes are existing within reviewing those activities there, and that's something that we'll have to pick up separately.
If I may just come back. Thank you very much for that. Yeah, I understand that. So just two things. Firstly, pharmacy first. Should the ICB not be scrutinising pharmacy first and understanding what's going on there, please? And secondly, you mentioned, is there not a software that will show something like to save your time? So, which basically would say, let's say it's a pharmacist in a GP surgery, sees a patient, and then later on down the line, the patient ends up being admitted. And surely there's a software or something that will highlight that that patient went to hospital, and it will look back at who made what decision when, and that's obviously a way of audit, isn't it? I just suddenly thought off the top of my head. Thank you.
So from a pharmacy first, I suspect there are audits and other processes in place. I'm not aware of what those are, and we'll come back to the processes around that. From your question around software, unfortunately, there isn't a process. And I can absolutely see where you're coming from. Is if a patient is seen, they're admitted, or something happens. It's only if a discharge or something, or a complaint or something else is made, that then there's sort of that root cause analysis around that patient going in. And yes, it's really important to be able to see what decisions are made to actually highlight educational needs around clinicians. Unfortunately, the only way to do that at present is a manual search from that point of view, if it's subsequently highlighted to you to review that patient.
May I come back again? Sorry, very quickly, very briefly. Yeah, I hear what you're saying, 100%. But I'm sure you agree it's possibly a way forward, and perhaps the ICB can take this higher up, because actually, are the government doing something as the NHS? And obviously, it's not NHS England; it's changing. But it sounds like we really need it, don't we?
I think it's important to be able to, because you don't know what you don't know, is the honest answer. And I think it's really important to be able to review your activity and the decisions that you've made as a clinician, to know that you've made the right decision. And that's where I think sometimes actually continuity helps, because you can subsequently see, you make a decision around a medication, you then see the follow-up the patient, you can see the response to that medication. With the way that general practice is at present, where you may not necessarily see the same clinician, it's difficult to know what the outcomes may be. And I absolutely agree that there'll need to be some considerations and thinking, is that how do we learn from the decisions that we make moving forward? How we do that is $1 million question, and I think that would need some time to reflect on how we can take something like that forward.
Excuse me, Chair. I agree, but when we're giving patients appointments away from a GP,
yeah,
and so therefore it's not about the GP, the continuity. We're giving roles of a GP who's done anything from 5, 7, 10 years training to other people. So I do think it's something that we really need to consider, because otherwise we're walking into a perfect storm, really, if lots of people are being missed. And we can have all these fancy targets for cancer weights or cardiology, but if we're not analysing what's going on, I am concerned. And thanks very much for your answers and listening to me. Thank you.
No worries. Thank you.
It was just to pick up on the pharmacy element, because obviously Mark's here speaking from a general practice perspective. So you're absolutely right, the ICB does have oversight around the Pharmacy First scheme, and there is a scope of practice around those 7 individual areas, those common conditions that I talked about, and the governance will work in a very similar way in terms of general practice, with the oversight around that scheme. So please be assured that that is the case. There is governance wrapped around that, but it is something that we will consider in terms of what you've said today, and take that away. I think that there is some audit work as well, isn't there, Vicky, that happens around the Pharmacy First scheme as well. So it was just to provide that additional assurance around pharmacies.
Okay, thank you very much, everybody. Councillor Edgeler.
Thank you very much, and thank you for your presentation and your report. Right, I pick up Councillor Hood's comments about secrecy and what have you. And might I suggest that probably, I don't think it's us as councillors to go into doctors' surgeries and saying, you know, you should be doing this, you should be doing that. With all due respect, would it not be a good idea for the ICB to write to all doctors' surgeries and explain, you know, about secrecy and please? So that's my first question. My second question is, I'm losing my voice, sorry. Doctors' appointments, all right, we know they're on their increase, but again, it comes down to the planning stage. You mentioned it earlier about working with the boroughs and that on planning. You know, and there used to be a written agreement, please tell me I'm wrong, if I am wrong, where if a planning application went in and it was below 500 houses, then the doctors and everything didn't have to give some sort of report, and it was put, you know, to one side. Now we're getting a lot of applications coming in where they're just under the 500 houses, you know, and I don't know whether that still applies about 500 or whether it doesn't. But we're getting a lot of applications, and then it's not taken into account about doctors and what have you. So what can we do to improve that situation? And I take the councillor's point about mental health, and it would be good to have somebody come here, because as we know, mental health on the increase and everything, so it would be good, really, too. So I picked that point up. My other points are about patient participation groups on doctor's surgery. Now, and this is a matter for all councillors actually, if you're not a member of your patient participation groups at your doctor's surgery, please become a member, because these are the things we can take back from this health committee to the groups out there, you know, to the surgeries and everything, and it becomes quite interesting, because we at our participation group, we've had social prescribing people come along and give a report. We've had pharmacy, only this week actually, the pharmacy came along and give a report about the work they're doing. So, you know, it's really important, if you can, become a member of your joint participation group. And you talk about things are improving, but I can't see, personally, from where I'm sitting and what my doctor's surgery, I don't see any improvements. We're still a 3-week waiting list for doctor's appointments. I know of someone that's looking for a neurology appointment at the hospital. 12 months waiting list. You know, where are we going? So I don't personally see any improvement, but you're telling me there is, so I take your report as read. Thank you very much, Chairman.
I accept that, you know, they're not improvements everywhere, and that's why at the very start I talked about variation. So there's not improvements across everywhere that are tangible. Some practices are still struggling, and we're working with those practices on improvement plans, trying to support them to get to where they need to be. You talked about the planning again. Yeah, you know, unfortunately, we do have, we're very fortunate in our ICB that we have a member of the team that leads specifically on planning and planning applications, working in partnership with the local authority to understand that health benefit, and regardless of however many houses it is, we make sure that our health services locally can pick that up. Mental health, obviously, we spoke about that earlier. We can ask somebody from the mental health team to come and present to you. There was an earlier... PPG. The PPG, absolutely. Get involved in your patient participation groups if you can. And that was the other thing, sorry, the governance thing that you picked, the confidentiality you picked up at the beginning. There is no reason why we can't write to our practices to remind them around confidentiality, and we'll be happy to do that following this meeting today.
Thank you very much. I mean, I appreciate that, and I think we all would appreciate that as well. Thank you. But I'll keep my eye. I sit on the planning sometimes at the borough, so I'll keep my eye on this situation with the doctors.
I was just going to come in very quickly, if I may. I think, although we've seen a 2.3% increase in appointments, and that is for Staffordshire, demand has probably increased even more so than 2.3%, which I think makes it even more difficult for citizens to get appointments as that demand increases. So that's the increase in capacity. The demand for those appointments, you know, as we've seen, as patients' chronic conditions and more people develop chronic conditions, there's more demand on services than still that can be reached, unfortunately.
Chairman, can I just go, what can we do about this then? You know, I mean, you sit there on the planning committee, you're listening to all this, and yet you see these houses being built, but there's no infrastructure to go with it. And health. And I've said many times, if you haven't got your health, you've got nothing. Thank you.
It's moving to a preventative agenda. We have got to move around the Titanic towards the prevention, as we've heard earlier, around weight reduction, alcohol. It's a massive, massive issue around moving towards a preventative agenda. But with our clinicians working really hard at the coalface, it's really difficult to move towards that preventative agenda because that needs additional capacity and resource.
Okay, thank you very much. Councillor Hood.
Thank you, Chairman. First of all, I'd like to just very briefly touch on what Councillor Edger has just said. We should not be discussing planning at all. You're a member of the planning committee, so am I, so therefore we cannot touch on anything like that in case it prejudices a planning application. The point that I wanted to make, I'm so sorry, I didn't get your name. Yes. Sorry? Dr. Stone. I'm Mrs. Hood. Housing options. Part of my community is homeless and rough sleepers. My portfolio covers that. And I really would hope that every doctor's surgery has a contact number for their local district and borough councils for them to pass on that number, because anyone is able to call the housing options teams if they're having difficulty with housing, if they're a rough sleeper, if they're homeless. So I would hope that all of your primary care surgeries have that. Thank you, Chairman.
Councillor Norman.
It's a planning issue, really. Every planning application should consult with the ICB and with Staffordshire for transport and for education. For example, the Coulter Lane one there, the County Council has not objected to any education, no education demand on that. And the ICB will wait to see what they say about it, because every application is objected to on infrastructure grounds, but then always infrastructure is always consulted on, with it Severn Trent or whatever. So Lichfield District Council, there's always a consultation in the report. So I think that's something you need to sort out at your end, I would suggest, to those who are not seeing those in their applications.
Councillor Porter.
Yeah, each planning application should provide a 106 agreement, which is to do for roads infrastructure, and that money should be used for the infrastructure and everything like that. So, yeah. So there should be some provision there for things like the health centres and everything like that as well. Thank you very much.
Councillor Mansfield.
Thank you, Chair. Thank you for the presentation as well, really, really helpful. I wanted to come back to Councillor Hood's comments about community pharmacy and just checking that at a time when they're doing loads more consultations, which is great, that we're happy that that capacity is there and it's sustainable. I work for a health charity. I was talking to somebody last week, and I think it was type 2 diabetes treatment, that they said that pharmacies provide at a loss. So if you've got lots of patients with type 2 diabetes, if you're in a deprived area, for example, that could be something that loses you money as a business. So I guess just checking that we feel, when we're asking them to do more under pharmacy first, that capacity and sustainability is there for them to be part of the system.
Yeah, I would say that the pharmacy community is just as much under pressure as the GP practices. I think we're just feeling this across the health system in general. They don't have to do it, so it's these things are voluntary. So if they don't want to provide the services, they don't have to. But what we need to do is to ensure that those services are available within that community somewhere.
Thank you, Stafford. Thank you.
Councillor Brown.
Thank you, Chair. Could you just have clarity then on the planning application and the amount of homes, please, for a future? Just that we've obviously had a bit of a conversation here, and I do believe that Councillor Edgerly is quite correct in there's a threshold where if you have a certain number of homes, then your GP services, there might be a report by all the borough councillors about the planning applications, but unless there's a certain amount of homes, there aren't the healthcare requirements for the S106 money. Thank you very much.
Is there any other questions? Okay.
3 small points, really. I would say a lot of my residents, I've been in some meetings recently, talked about social prescribing. What are they? Who are they? What do they do? So it isn't known what they do. So, you know, some more information about that will be useful. Similarly, the NHS app. I've got, recently somebody said, oh, you can book your doctor's appointments, and then this is on Facebook. No, you can't, I didn't know anything about it. So equally, a lot of people don't know what they can do and how to access it. So I think that's quite important. And like you were saying earlier, wasn't it, I think that, so older people can use it, but then there's also some that can't. But even those who are able to use it, they don't know what's there and what's available. And I would say that like online consultations, I haven't heard anything that our local surgery does it. I'm sure they must do, but I haven't heard about that. So, and one thing, I wasn't going to mention this, but you all have, about planning. And I know we've got a lot of houses that have been built in Penkridge recently. We've got 1,169 in the next 5 years. It's always talked about GP surgeries, and they are consulted, and they always come back and say, we've got the capacity, but the residents don't think there is the capacity because they can't get in, they can't have blood tests, and they find it hard to see the GP. Unless it's urgent, if you ring up, they do ring back. So I've always had excellent care, but people who've got chronic conditions, long-term conditions, do find it difficult to make appointments. And then they say, we're having 1,100 houses, how are we going to manage? And that is, I know it's difficult, but, and we have to answer those questions as well. Anyway, that's just an observation. Thank you.
Yeah, we will present more information on social prescribing, what they are, etc. We're happy to do that. In terms of the planning, I think this warrants a bit of a conversation that might maybe come back with some individuals that have the experience of understanding how it works. But what I will say is GP practices, they generally do speak for themselves when they say whether they've got capacity, so we can only appreciate what is going through their door, and they should kind of engage with their local communities around that. And going back to the PPG, be using that as a mechanism to be having conversations with their patients around if there are problems, if there could be perceived problems or actual problems. It needs kind of further investigation in each one, doesn't it, really? And then there was another thing that you just picked up as well.
NHS app.
The NHS app. There's quite a lot of use of the NHS app now, but there aren't many practices that will book appointments on the NHS app. And the reason for that is the release of them. And because, remember what Mark was talking about earlier in regards to navigating an individual to the right place, to the right clinician, the right specialist at the right time. Booking online means that you might not be able to do that unless there's some sort of algorithm before, which the NHS app doesn't allow. But we have been doing quite a lot of work on promoting the NHS app. We're doing, I'm trying to think of there's something going on at the moment called Volunteering for Health, which we just talked to Support Staffordshire and VAST around having the voluntary sector possibly help us a little bit more with getting patients on the NHS app. So, you know, community champions that might be digitally enabled, so maybe going to sit-in practices to help patients while they're in the waiting room, etc. So we're looking at doing that as well.
For that. I just have to say, the surgery's got a callback system now, and I think that's working quite well. So I've heard. Anyway, so that's an improvement, isn't it? Yeah.
Okay, thank you. Councillor Parton.
Yeah, it's just an observation, really. It's all right building all these practices in the 106 agreement for building more practices, but I wonder where they're going to get the staff from to staff them. So, you know, it's a catch-22, really, that, you know, they can build these premises, but it's getting the staff and keeping the staff to keep them going. So, you know, it's a catch-22, really.
Okay, thank you. Councillor Norman.
Yeah, it must be relatively simple. There must be a formula. If you know, the county council is consulted on schools, and they work it out by the number of young people that will be moving into those homes, and know what the sort of homes are and so on. And it must be the same for GP practices and the ICB. There must be some formula somewhere that says this many patients are likely to come from this number of houses or these types of houses. So it must be somewhere. I'll try and find out tomorrow night, actually, at my own scrutiny committee. But I should be able to find the answer to that, but I'll share it if nobody else is doing it.
Yes, that's been asked already, and we've got that written for yeah. Does anyone else have any other questions? No? Okay, so thank you for your report. I did pick up a few recommendations which the committee want to make. Is that correct? Yes? Okay. So we recommend that the ICB write to all doctor surgeries to highlight the need for privacy and GDPR compliance in relation to patients having conversations with reception staff. We will also like to recommend that the ICB consider a need for the ICB to work alongside acute hospitals and general practices in order to establish a mechanism to audit patient and hospital admissions and a root cause analysis in relation to patients which have been seen at general practice for learning. We also request to receive information around what the thresholds are in relation to new builds in Section 106 monies and general practice requirements. Councillor Brown isn't here at the moment, but she would, if she wants to, email me all the stuff that she wants. And we also request for more information about social prescribers, what their role is and where they are based. Is that all the requests? Yes?
As long as they email and not actually writing letters, because don't we receive by the DB practices if patients reception, anything to go on. So email is my advice.
I'm sure they'll use email, Councillor Norman. Okay. Okay, thank you for coming, and I appreciate you coming here today. What's next? Oh, and we're now going to move on to the work programme.
Thank you, Chair. I was just pulling it up. This is just for the committee to note the work programme and the updates, if anyone's got any comments they want to make.
Councillor Norman?
Yeah, I can't see anything in the future items for scrutiny for social care, how social care is happening at the county. It's always outside bodies, but I wonder if there was an opportunity to look at social care issues. And the other thing is, it's not on the agenda about county and district reports, district and borough reports back. That may be because you haven't had any, but can I assume it'll be on the agenda next week? Thank you. Because mine will be interesting. Thank you.
Can I just ask what specifically in relation to adult social care did you want to look
I can't say anything about social care, you know. That's all. And surely we have an interest in how that's progressing, the various aspects of it. Maybe in there, like for older people, for example, what the county council are doing there and how they're getting on and what the problems are and so on. I mean, it's a bit vague, but I'll try and put something in.
I was going to say there are some specific adult social care kind of related items, but what will happen is the committee in May will then consider what they want to look at the next work programme, and then any items can be suggested and scoped at that meeting.
Councillor Greatorex.
Yeah, just in relation to Councillor Norman's question, there is obviously a subject down for the future for adult social care. I think what would be interesting is to look at the providers and whether the market is changing, whether it's getting more difficult to get providers in the right cost level. And similarly, because it's a hot subject at the moment, it's on the future agenda list, but children with SEND and looking at the health aspect of it, I think if that can be brought forward, because that's something that's become a bit more pertinent because of the cost of the transport, but specifically we'll look at the health aspect of it. If that can be heightened in the agenda.
There may be, that might be one that we'd need to work with the safeguarding committee with as well, just on where that specifically sits in relation to.
Zach, can I just ask you, has the white paper been produced about SEND, the white paper?
I'm not sure. I will ask the question.
Councillor Brown.
Thank you, Chair. Just a couple of things. Firstly, the next meeting on 23rd of February, we've got University Hospital North Midlands efficiency savings and some others there. At least Staffordshire Borough Council Health and Wellbeing, as I've mentioned a few times, they are concerned about issues, local issues involving University Hospital of Derby and Burton. So when we're having all these figures for other places, please could we also include Derby and Burton NHS Trust's figures, firstly. Secondly, also they raised an email sent to you, waiting times, which I believe we're supposed to be having some updated waiting times, were we not, from... but anyway, they really want to emergency department waiting times, cardiology waiting times, and the stroke service and neurology. That's a subject we need to know what is happening, and I think we've mentioned that before. Also, the only other one they did ask was could someone from UHDB visit them, but I have spoken to the officer, and we'll look at that again. And waiting times for emergency department and cardiology, yes, yeah. And also discharge for the elderly, lack of services in East Staffordshire Borough Council. I'll send an email to you about those. So thank you very much for listening.
Thank you. Councillor Wallins.
Thank you, Chair. And similar to what Councillor Brown just mentioned, would it be possible to get an update on the maternity unit, Samuel Johnson? I know I've been banging on that for a while.
Yeah, that is something that the committee are keeping an eye on. I understand that they're going out to consultation again. So when, and I think it's unclear at this point. Yeah, it's both county and it'll go locally as well, because the scope's slightly widened. But I can email members about that separately.
Councillor Greatorex.
Yeah, just to respond to Councillor Edger's question, the white paper on SEND hasn't been published because what the government's seeking to do is take away the responsibility for SEND from local government to national government. How they're going to do it is another matter. So it'll be a long time before that report is produced. We may well want to scrutinise that when it is in play. But in the meantime, I think we've got enough that we need to look at from a local council point of view to consider on the agenda.
Martha?
Thank you very much. Just a couple of points really to pick up on, because you jogging my memory there and from the session today. So there's kind of three key areas I just wanted to touch on. Pharmacy First, obviously we've heard about Pharmacy First this year. Well, today. We heard about it last year. We had a lot of feedback coming through to us, which then we started doing a couple of enter and views, which is our statutory duty, just under the CQC. Places can refuse us entry, Most don't, because they know we're there and we want to help them, support them, share good practice, make recommendations where services can improve. So we did 2 or 3 of the pharmacy entrant views, and the same themes were coming through. So we're actually now running a survey on Pharmacy First for the county. We are asking pharmacists, GPs and patients, sorry, it's a medication tablet alarm, so we're running that at the moment. So if you, in your communities, if you are hearing things, please direct people to Health Watch, because that is what we're trying to do, to see what is going on different levels, because there's various intricacies that are making the system even more complex, that if they can be navigated, then that takes a whole level of complexity out of it. The PPGs, I just wanted to touch on. We're looking to do a lot of work this year with PPGs. We're working with East Staff's district PPG at the moment to look to see how we can embed and support other areas to do what they're doing and kind of and grow rise in there. And we're also looking for what we're going to focus on next year. So I take your point on social care, where you've mentioned social care today. We've rarely done a focal deep dive on any social care element of what we do. So we are looking for anything that you are hearing, suggestions, key themes that are coming from your residents, or the councillors, anyone within Staffordshire, so we know what we need to focus on. Next year could potentially be, well, 26, 27 could be our last year. I found out just before Christmas that we have got funding. That is thanks to Staffordshire County Council for taking and making that decision. No information came from the Department of Health advising local authorities on what to do. So actually, we're very grateful to have been able to and afforded that position. So really for us, it's making that our last year, if it's our last year, count, and also embed what comes after us. We're not about saving the brand, it's about our residents for us. So yeah, just wanted to pop that before I forgot. Thank you very much.
That's excellent, thank you very much. Could we just have the link sent to us, please, for the survey, and then we can disseminate it as much as we can. Thank you very much.
I'd just like to say one last thing. Councillor Brown, if you want to make sure you CC me and Zach in your queries, and I'll make sure you get all the answers that you want on those, okay? Okay. Is that everything? Okay, so I now close the meeting. It is 12:32. And that's it. Thank you for everyone for coming, and you did brilliant questioning today. Thank you.